by Department of PMR SVNIRTAR in association with IAPMR and Odisha Association of Physical Medicine Rehabilitation. Friends, regenerative medicine in management of chronic musculoskeletal pain disorder is growing in very fast pace. It is now an important aspect of our practice in pain management. Ozone is playing a great role in our pain practice management. It is a low cost, easily prepared, and used as intra-articular as well as intradiscal and many other ways. Today we have with us one of our expert senior member, Dr. Nilachandra Singh. He is professor and head of PMR at Regional Institute of Medical Science, Imphal. He has completed his FIPM after completion of his MD PMR from New Delhi. He has done his fellowship in pain management from Daradia Pain Hospital, Kolkata in 2013. Also, he has done certificate course in rheumatology from Grant Medical Foundation, Pune in 2018. He has lot of research and experience to his credit. To name such research projects, he has undertaken low-cost custom-made urethral clamp for incontinence in spinal cord injury by Science and Technology. Government of Manipur sponsored that. He has undergone many short course on pain intervention, including spine endoscopy. He has a lot of publication to his credit. He has done 15 research paper published in international journal, 31 research papers in national journal, and 9 research papers in state journals. He has almost attended 15 international conferences and national conferences in pain intervention and rheumatology, in addition to which our specialty. So he has a vast experience in pain management, especially spine pain management. He is one of the physiatrists among us who has exposure in endospine also. So as far as my knowledge, his department is doing great job in pain management, especially spine intervention. So without much waste of time, I would like to invite Dr. Nilachandra Langyam for his presentation, Nilachandra Singh for his presentation on ozone in PMR practice. Welcome you, sir, for today's webinar.
Thank you, Dr. Pabitra. A very good evening to one and all. First, I thank Dr. Pabitra Kumar Sahoo, ISWADI PMR, SVNIRTAR, for the nice introduction. Indeed, it is a great privilege for me to talk in this forum. Once again, I thank the organizer of this webinar for giving me the opportunity. Thank you. So to start with, ozone, as everyone knows, yes, sorry. Okay, so I'll be covering under the following headings. One is first is about briefly about the introduction of the medical ozone, then how it is produced, then its uses in our specialty, then mechanism, indication, and the contraindication in these problems, then mechanism in osteoarthritis and other conditions, and briefly about the evidence levels and the future program. So ozone, as we know already, as we all know, is a gas in the atmosphere with a triatomic oxygen molecule that protects everything living in the earth from harmful ultraviolet rays from the sun. Ozone name comes from the Greek word ozone, that is to smell, and the ozone is produced by the action of the ultraviolet rays and the thunderstorm on the atmospheric oxygen. As a molecule in the Earth's stratosphere, it protects us by absorbing harmful ultraviolet radiation, and without ozone, it will be very difficult to survive on this surface. So briefly about the ozone therapy, to mention, ozone therapy for treating the patient is not a new one. The first ozone generator was developed by Werner von Siemens in Germany as early as 1857. And during the First World War, ozone was used to treat transfoods, wounds, gangrene, and also for the effects of the poison gas. And in 1915, Dr. Albert Wolff of Berlin used ozone for treatment of the colonic cancer, cervical cancer, and the decubitus ulcer. And ozone was extensively used during the Second World War for the treatment of war wounds. So this is briefly about the ozone therapy. Then coming to the medical ozone. Medical ozone is a mixture of oxygen and ozone in different concentration. And the medical ozone is produced from the pure medical grade oxygen with the help of high voltage electrical discharge. And we should remember that ozone should be prepared freshly on the site for the immediate administration. Otherwise, the effect which we want to get will not be achieved. So the exact dose for the treatment of a particular disease should be depend on the trained physician, depending on his or her treatment of the condition. So we should always remember that ozone should be always freshly prepared. So just to mention briefly about the properties of the medical ozone, as I mentioned earlier also, medical ozone is naturally occurring triatomic molecule of oxygen with a molecular weight of 48 kilodalton, and medical ozone is an unstable compound. Please remember this, the half-life is 20 to 30 minutes only at 20 degrees Celsius. And we should remember that it is colorless and the smell is pungent. And the one good thing is it has an antiviral effect and disinfectant and antiseptic properties. So let me tell you briefly about the physiological effects of ozone. It has role in tissue healing by bone regeneration and by increasing the expression of growth factors like vascular endothelial growth factors and transforming growth factor beta. And it also helps in immune modulation by activation of the macrophages and the regulation of the inflammatory cytokines. And it also helps in regulation of the prostaglandin and the bradykinin by increasing the prostaglandin synthesis and also increase in the bradykinin release. And it also helps in ozone oxidase and antioxidant regulation by ozonolysis and interaction with glutathione system and signal transduction and also cellular antioxidant regulation. And it has role in modulation of the oxidative stress and inflammation by reducing the pro-inflammatory cytokine, modulation of the macrophages, and the decreased nuclear factor kappa beta activity. And it increases the microbicidal activity. And ozone helps in enhancement of the tissue oxygenation by increased oxygen delivery by RBC and improved tissue oxygenation. And it has also role in activation of the nuclear factor 2 and inhibition of the nuclear factor kappa beta activity. Then how this medical ozone is produced? There are different methods. I'm mentioning here only 5 methods, but out of these 5, corona discharge is the most commonly one that is used. So it can be produced by corona discharge method 1, another is ultraviolet radiation, then electrochemical process, then cold plasma and the radiochemical method. So in corona discharge generator, it should include corona cell with an air gap within the cell where electrical discharge takes place, then dielectric material like ceramic or quartz that distribute the electron flow evenly across the air gap. Then it will need a high voltage transformer for increasing the voltage of the electrical discharge. Then, of course, power supply to regulate the power to the transformer. When high voltage field is developed, then it will convert the oxygen in a stream of dry air or oxygen into ozone. So electrical discharge split the oxygen molecule into elemental oxygen. Then this oxygen will bind with another oxygen molecule to form ozone. So this is about the formation of the ozone by corona discharge method. So this is one of the ozone generator that is used in my department at present. So what we do is oxygen source has to be connected to the generator through a gas tube. Then we have to set the oxygen outflow at 0.5 to 1 liter per minute. Then desired oxygen concentration is set in the controller to 20 to 30 microgram. Then oxygen generation can be indicated by pungent smell or by an indicator. Then this prepared ozone can be taken in a syringe, that is ozone resistant syringe. One important thing is whether ozone is really coming or not when we prepare this. That is very important part in the process. So to check that whether ozone is really there or not, one of the easiest thing which I do practice is the first one, that is tear in surgical glove. Say we put a surgical glove near the ozone where we prepare that, then the glove will tear. This is the simplest one. Of course, other methods are also there, like telling of the mercury with stars plus potassium are there, then change of the benzene paper to brown. So like that, there are different methods are there, but easiest one is the first one. Now coming to the role of ozone for the back pain, that is low back pain. Intravesical ozone injection was first proposed in Italy in 1980s as a treatment for the herniated discs. There, mixtures of ozone and oxygen can be given directly in the discs. So we should remember that the therapeutic dose is 20 to 30 microgram of ozone per ml of oxygen. Then studies have found that 25 to 30% concentration of ozone induces dehydration of the disc nucleus and also inflammatory reactions. So most of the trials has proved that 25 to 27% ozone will be optimum for the therapeutic effect in disc herniation. So now we need to know the indication and the contraindication. We cannot go each and every patient. So what are the indications that one should know? One is we can go in those patients with disc prolapse where there is contained hydrated disc bulges or protrusion or extrusion, which are causing nerve root irritation. Then next one is in degenerative discs causing discogenic pain without any nerve root compression. So this indication, we should always assess the patient and we should think about this. And once you remember that, it should undergo only those patients where disc hydration is there, that will be confirmed by MRI. If there is no disc hydration, then it is better you don't go for ozone necrolysis or ozone discectomy. Then we have to know about the contraindication. What are the contraindications? So to mention a few, there are of course many more, but some important one is glucose 6 PD deficiency, then bleeding disorder, then patient with local infection, then uncontrolled diabetes, then patient with pregnancy. Then one should not go for this procedure when there is distorted anatomy. And another one is very important one also, patient with Cauda-Equina syndrome, fissures, one should not go for this ozone necrolysis. So we have to keep in mind this indication and the contraindication before undergoing. Then how this ozone works, that mechanism in this, there are of course several mechanisms. So one of the most important one is breakage of the protochiral bond in the nucleus pulposus. Thereby, the water holding capacity of the disc will be lost, causing shrinkage of the disc volume. Then another one is analgesic effect. Then the third one is anti-inflammatory action due to inhibition of the formation of the inflammation-producing substances. Then the fourth one is tissue oxygenation is increased due to increase in 2,3-diphosphoglycerate level in the red blood cell. Of course, the last one is it increases in the microcirculation. So this is briefly about the mechanism of the ozone in disc herniation. So I'm just showing here what you need to prepare before undergoing this ozone discectomy. You have to prepare ioxyl, that is radio-opaque dye. Then you have to arrange syringe, you have to arrange local anesthetic, that is without preservative. Then you can go core, this one 22 gauge needle, then epidural set, of course, for filtering the ozone, then 18 gauge the needle. So these are the things you need to, one has to arrange before the procedure. Then coming to the procedure, we have to keep the patient in prone position with a pillow under the abdomen. That is just to avoid the lumbar lordosis. Then all the procedures should be performed under CM guidance. Then we have to focus the CM in AP for the identification of the affected discs. And the CM should be cranially or cordially moved to abolish any double end plates or achieve widest possible view of the disc. This is called squaring of the vertebra. So we have to arrange this. This is the one of the most important part for this procedure. So if there is double shadow, your target may not be achieved. So we need to make the vertebra squaring. Next, CM is rotated obliquely to visualize the facet joint. The facet joint, one has to remember that facet joint should be at the center of the end plates. So we should always check this. And before going for the insertion, one has to know about the Kembin's triangle, which is the needle entry point. One should remember the boundary. So here, what I want to tell you is, without knowing the anatomy, one should not go for the intervention. This is not only for ozone necrolysis, for any intervention. If one doesn't know the anatomy properly, one should not go for this intervention. So anatomy is very important part in intervention, pain intervention especially. So to mention Kembin triangles, it has boundary. One is superior articular process of the lower vertebra. Then another one is the superior end plate of the lower vertebra. Then we have to know the exiting nerve root. Here I am showing this is the Kembin triangle, and this is Kembin triangle. Then this is the trigonometric. This is the exiting nerve root, the superior end plate of the lower vertebra, and this is the superior articular process of the inferior vertebra. So this is the Kembin's triangle where your needle has to enter. Then another confusion which people confuse is shape triangle. So just for the knowledge, I'm mentioning here the boundary of the shape triangle. So it is the boundary are inferior edge of the pedicle, the outer margin of the posterior aspect of the vertebral body, then upper margin of the exiting nerve root. So this triangle is used for the transforaminal epidural steroid injection. So one should not confuse with Kembin triangle and the shape triangle. Now, after the preparation of the patient and after proper localization, we have to prepare the area with antiseptic dressing, draping, and then the area is to be needle to be introduced. Then it is inflated with local anesthetic. Then at 22 gauge, 12 centimeter or 15 centimeter, depending on the body of the patient. For fat individual, then we need longer needle. So will be introduced into the Kembin triangle of the affected discs using tunnel view. So end-on view of the needle is important to achieve, and it should be performed under, as I mentioned earlier also, it should be performed under fluoroscopic guidance. Then after inserting this, the needle position is confirmed by AP and the lateral view. These are the two different view which I am showing here. This is lateral view, this is AP view. So you can see the needle position. So to confirm the needle position, we can give ioaxial dye in the disc that I'll be showing in my subsequent slide. So one thing is the needle should be placed at the center of the disc. This has to be inserted up to here in the lateral view. Then after this proper position of the needle, then we can go for injection of the ozone. So about 5 to 10 ml of oxygen, ozone oxygen mixture at the concentration of 20, as I mentioned earlier, 20 to 30 microgram per ml of oxygen injected into the disc. This is how we do. So this is the position of the patient, and this is in the oblique view. You can see this is the vertebral end plate. So the facet joint is here. It should be in the middle of the vertebral end plate. Then this is how the needle is introduced. Then in lateral view, you can see this. Then dye, after giving dye, this we confirm it. So this is, and here we are giving ozone. So this is how we do. Then coming to the post-procedure care, which is a very important part. Any intervention post-procedure is very important care, because many complications may come, or some may not come, of course, but we have to take extreme care after the procedure. So we have to keep patient in rest. Then we have to give broad-spectrum antibiotic, then rescue analgesic like paracetamol or tramadol, central acting can be given. Then coming to the rehabilitation after the ozone necrolysis, from day 0 to day 3, we keep patient at bed rest for 24 hours. We should not keep bed rest for too long. Then avoid any bending or lifting, then lumbar press if needed. Then we have to go for back school. This I won't mention in detail, as every one of you knows. Then from day 4 to day 14, then we have to start with back care in ADL. Then we have to start with asthmatic spinal strengthening exercise. Then from 3 to 6 weeks, then postural correction, core strengthening exercise, endurance, and aerobic training. This has to be incorporated in the treatment program. Then by 7 to 12 week, ergonomic education and maintenance of the exercise has to be done. Then another important one is, when should the patient return to work, is we can start sedentary jobs for after about 2 to 3 weeks if pain is free. Then physical job after 4 to 6 weeks with the clearance and adequate strength. So this one must remember. Now, advantage of the ozone necrolysis. One interesting thing is it is very cost-effective one. And another interesting thing is minimally invasive. As I have mentioned also, I have explained also, as you know, you notice. And another is high success rate with minimal side effect and a low recurrence rate. So these 5 things are the advantages of ozone necrolysis. But we should always remember about the adverse effect also. The patient may complain pain at the injection site in some of the patient, and there may be some muscle spasm. And of course, discitis may be there, but it is very, very rare. But till now, in my practice, I haven't come across any patient like this. So you need to take care of aseptic and antiseptic care very carefully. So one should not compromise in this. So coming to the evidence levels in low back pain about the ozone, according to the study conducted by Mohammed Izeldin and all in 2018, percutaneous ozone necrolysis for lumbar disc herniation is a safe, cost-effective, and a minimally invasive treatment of contained and uncontained lumbar disc herniation. And according to the study conducted by Dr. Gautam Das who is also my mentor and from whom I learned this ozone nucleolysis. And in their study, ozone nucleolysis for the management of pain and disability in prolapse lumbar intervertebral discs, which was a prospective cohort study, concluded that there is reduction in the BAS score and also ODI from the baseline to 3 weeks and even up to 2 years following the treatment. Then in a systemic review and meta-analysis study conducted by Francisco and et al. On ozone therapy as a treatment for low back pain secondary to herniated discs, a systemic review and a meta-analysis of the randomized control trial concluded that ozone therapy appears to yield positive results, low morbidity rates when applied percutaneously for the treatment of chronic low back pain. So this is all about this ozone therapy in disc herniation. So now let me come to the ozone in osteoarthritis. Ozone in osteoarthritis, again, another promising treatment for the knee osteoarthritis, and the studies indicate there is reduction in the pain and improvement in the function, and also it enhances the quality of the life of the patients. So to tell you about the mechanism, how it works in osteoarthritis is ozone stimulates production of the interferon and interleukin and initiate the production of the antioxidant enzymes. And it reduces the tumor necrosis factor alpha concentration, which is a pro-inflammatory cytokine, and activating the nuclear factor kappa B pathway, leading to downstream cascade of the pro-inflammatory cytokine. This is briefly about the mechanism of the ozone in osteoarthritis. So this is how we give ozone ultrasound guided. Then about the evidence level of ozone in osteoarthritis, according to the study conducted by Valerie et al., efficacy and the safety of ozone therapy for knee osteoarthritis, an umbrella review of systemic review shows that pain intensity and function significantly improve with ozone therapy. And in another study conducted by Carlos Fischer et al., comparison between intraarticular ozone and the placebo in the treatment of knee osteoarthritis, which was a randomized double-blinded placebo study, confirms the efficacy of ozone concerning pain relief, functional improvement, and the quality of life of the patient in patients with osteoarthritis. Now coming to the ozone in other musculoskeletal conditions, we have tried also in adhesive capsulitis, then in tendinopathies, then trigger injection like myofascial pain and fibromyalgia, but the evidence levels here is very low. So mechanism, how it works in other conditions is by it activates cellular metabolism and modulates the immune system, and also it increases the activities of the body's own antioxidant and a radical scavenger. And the last one is it enhances in the circulation. So about the evidence levels of ozone, in low back pain it is level 2, and in osteoarthritis also is level 2, but in other conditions is level 3 and 4. About the future prospect, looking ahead, the future of ozone in PMR practice is promising. First, there is growing interest in expanding its clinical use beyond the condition which I have mentioned. Secondly, we need more studies for integrating ozone with other regenerative medicine like PRP. We are already doing this study in our institute, major limitation is that the variability in the treatment protocols for ozone therapy to become more mainstream, we need more research, more study to standardize the guideline regarding concentration, ozone doses, then different condition. So how open and how many sessions? This need more research to come to the conclusion, and also the evidence-based combination for the validation. So overall, future research and clinical trials will have to refine the role of ozone in evidence-based rehabilitation, which potentially making it an elegant tool in primary practice. So today my take-home message to all is ozone therapy is very safe, minimally invasive, cost-effective, with minimum and least side effect, and with proper workup, it can perform even in daycare settings. And we should remember that the effectiveness and success rate is very high. This as high as 75 to 80%, and the recurrence rate or for the need for surgery is about 2 to 8% only. So it can be recommended one of the most valuable modalities in our practice. Thank you for your presence here. Thank you. Dr. Sahoo, please.
Thank you, sir. Thank you, sir, for your nice presentation. We have couple of questions in the chat box. Before coming to chat box, I have some queries also. You said during preparation to know there are certain indicators that it is prepared. That one is a tear in surgical gloves. What do you mean by that, sir?
So what you have to do is you can use the surgical gloves we are using commonly in our this one before any intervention. So that glove, any glove you can put near the tube where ozone is coming out. So there, once you put there closer to that your glove which you are putting, that will tear. That shows that ozone is coming out.
So it is
From
burst.
where
It will burst. It will burst.
Yes.
Okay. Okay.
There will be this one tearing of the glove. This is the
Okay.
simplest one that also I'm practicing.
Okay. 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 And regarding, can you clear something about there is no disc hydration or no disc hydration?
Okay.
How do you decide on MRI and where to prefer to go for ozone?
So this okay, very good one. So we have to go for MRI image, T1, T2 weighted image. So this, if we go for T2 weighted image, when you see for MRI, if there is disc hydration, you will see the whiteness in the disc. Once disc is low, the hydration is lost, or there's no hydration at all, then that will be blackened in T2 weighted image. So that will confirm the hydration of the disc.
Okay. Which condition will you prefer the ozone therapy? Disc, hydrated disc or non-hydrated disc?
Yeah, as I mentioned also, non-hydrated disc, if you give also effectiveness is not up to the mark, maybe there a little bit, but effect will not be what is we expected. So it is always better we go for ozone nucleolysis or discectomy in those patients with proper disc hydration.
So one query is, sir, why cauda equina is a contraindication to ozone therapy? You know, this cauda equina normally develops when the disc herniation occurs below the level of cord, say from L3, L4, L5. These areas where we expect a cauda equina from disc herniation. And these are the sites where majorly we find disc herniation and the cause of back pain. So why the cauda equina is a contraindication to ozone therapy?
So any progressive neurological deficit, one should not go for this ozone nucleolysis. So cauda equina is one such thing where this one, because you are giving one quite a huge amount of volume in the disc. So this is not a good one. And whatever is the condition, any neurological, progressive neurological condition, one should not go for this
Okay.
procedure.
So not only cauda equina, anywhere if there is any
Yes,
progressive
if it is
neurological
progressive.
deterioration, yes,
Yes.
it's a contraindication to ozone therapy. One question was that any difficulty in pushing the ozone in a tense disc? Do you find any problem during pushing the ozone into the disc?
Yes, very much. That is very good one. So we do come across this when we go for even my SR, my teams always face this problem. So there you have to rotate, you have to move little needle little bit here and there. So after that only we have to move. We have sometimes we need forceful injection of the ozone in the disc. So we need to change needle position little bit here and there. So after that we can give.
How often we can go for ozone? Uh,
You mean that
like,
repetition?
how often one can go for ozone therapy? How many times?
So, of course, that's why as I mentioned in my talk also, exactly there's no literature once you go for this much, 3 months, for 2 times, 3 times like that. But for me, in my practice, maximum of three sessions we give. At least I gave 1 month gap. Of course, some practitioners even do at 3 weeks or 2 weeks time repetition. But usually for me, minimum of 1 month gap is
So,
keeping. I'm keeping.
one patient with radicular pain with features of disc herniation, maybe with a hydrated disc is coming. So you have the number of options, like you have steroid for epidural steroid, you have ozone and other modalities. Among if all modalities are available with you, what modalities you will be prefer for this management of discogenic pain? If so, any preference order like epidural steroid, ozone, and other modalities in preference. What is your preference? What is
Okay, so
discal?
let me answer your question. So what we do in my center, what we follow is we have a protocol that patient with what you said radicular pain, pictures of radicular pain, we don't directly go for ozone nucleolysis because it is an invasive procedure. Of course, minimally, but we go for in those cases we give NSAID, of course. Along with that, we give epidural steroid. So epidural steroid, at least one week gap, we may give 2 times or 3 times. Some patients relieve even with one doses also epidural steroid. So we tried with epidural steroid. If patient is not improving with 1 dose, 2 dose, then we go for this therapy, ozone, or other modalities. So ideally, we start with epidural steroid along with your physical therapies.
Do you have experience of any cocktail modality of treatment? You give steroid into a disc and steroid epidural into the nerve root. Do you
No, see, frankly speaking, in my practice, what I do is we give ozone also, and we give transforaminal epidural steroid also. So that gives ozone is action comes later, but if we give transforaminal epidural steroid from the day of injection, patient got relief. So next day, almost all patients were very happy with this epidural steroid injection and ozone nucleolysis combined. So that's why in many of my patients, I combine these two procedures.
so you prefer a
The
cocktail
same
mechanism?
same needle entry position. So with changing here and there little bit.
One delegate has asked a question. One of the rare complication was discitis. What can you do to prevent it? And if it happens, how do we treat the discitis if it occurs because of ozone therapy?
Okay, so this discitis, as I said, everyone know this is this one dangerous one once it happens. But to me, till now, with the blessing from the Almighty, I'm yet to come across this condition. And moreover, what I avoided is that giving the dye in the discs. Once we are confirmed that we are safely in the discs, I'm not giving the dye many times. Of course, in some of the patients I give, but many times I avoid giving dye in the discs because that may again increase the risk of having the discitis. So to reduce that, I avoid this giving dye many times in the patient. So there is one. The another one is, as I mentioned earlier also, aseptic and the antiseptic precaution one should not compromise. See, once you do that properly, then chances of discitis, I think, will not be there. Then I haven't come across also till now. Of course, if I mention this, one of my friend, which we did the training at Daradia, and so she was a lady, and she was telling me in one of the meeting in the conference, she was telling that I did ozone reclassification. One of my patient got discitis. So after that, she stopped doing this ozone reclassification. Of course, her husband was an orthopedic surgeon. Somehow he treated. She was telling to me. So there are chances are there, but we have to minimize by proper this one aseptic and antiseptic precaution and the technique what you are doing. That's the thing.
Okay, what is the placement of needle in the disc, that when do you need a dye to confirm and when do you don't need any dye for to confirm?
No, here this is the it depends. It is the experience of the treating persons. So because when I insert the needle, I know that this is the disc because the feeling of the disc is different. Okay, then another thing is even in the X-ray, in the fluoroscopy also image position, the needle position, that also confirm. And your sensation of the feeling of the disc will be different from others. So from there also I stop. Of course, I also give dye in some patient, not for every patient. So so confirmation and the experience is also needed. Otherwise, at the beginning, one is to go for the dye.
Okay, it's a blessing situation that you have not come across any of your patients having discitis. However,
No.
if you have if any patient of your patients having discitis, then how do you plan to manage that condition?
No, that we have to give antibiotic, proper antibiotic, then proper care, rest, then we have to spinal support. Many things has to be done. So, and the symptomatic management has to be taken up along with that. So that is a big issue that once it comes. So you have to admit the patient, you have to observe every day properly. Then only after that the solution will come.
Okay, one more question. Does disc distraction increases disc hydration and lateral plan ozone therapy?
That's why repetition is needed. In few of the patient, I do repeat this ozone nucleases. It's not that what we are giving will be 100% effective, or and the concentration of the ozone again, today's preparation, tomorrow preparation may be different also. So it's not that all the this I mean, that we are giving that ozone will be effective. So repetition in some patient may be needed, and the dehydration of the disc also from patient to patient, at least some difference will be there. So since it is there, the effectiveness also will be there. The difference in the effectiveness. That's the thing.
Okay, coming to intra-articular ozone into the knee joint in osteoarthritis knee. Here also, do you have experience of injecting ozone along with the visco supplementation? Do you prefer?
Yes, that's why I mentioned in my talk also in my institute, some of my PGs are doing, I mean, this one, their thesis on this also combination with PRP, then combination with ozone, combination with viscous supplementation. That thesis are going on in my institute.
Does this injection of steroid along with ozone will contraindicate to the
No,
activity of the ozone therapy in the joint?
I don't think so. We are also that also we are giving also in some patient, not all patient, that also we are giving. That patient doesn't have any this one.
Any paper published in this regard with ozone with steroid in intra-articular into the ONE?
From my side, you mean to say?
No, no. Any literature you have come across where ozone along with steroid is injected into the knee joint?
That one is that I haven't come across that literature. Of course, people have tried that.
Okay. Any painless time period in ozone therapy? The question is confusing.
I can't
When
see.
painless time period in ozone therapy? One more question, whether the canal diameter is considered, like somebody is having a canal stenosis. We are very much fond of looking towards the amount of canal diameter when we look for MRI. Does it has any relation with ozone therapy? that if somebody the
See,
canal is very much compromised, will give or not?
no, if the canal is spinal canal stenosis, ozone will not have any role. Ozone is effective only in disc herniation, disc prolapse. So if the canal and stenosis is because of the herniated disc, then ozone may work. Otherwise, actual canal stenosis, spinal canal stenosis, ozone will not work.
Okay, sir. What is your opinion on extruded disc? Sometimes we see in sagittal plane of the MRI that disc is extruded into canal. So
No, extruded disc also it works. I have given many patients. Even I tried in 3-4% of the sequestrated discs. I don't know, somehow it was working to some extent, not up to the mark, but it was working. Maybe because of that, the sequestrated disc was pressing near the nerve root, so that was reduced because of this one giving ozone. So even in sequestrated also I tried in few patients, but extruded disc it works.
can it be used for the NOR block procedure also?
That we have to see, we have to do research, but we are yet to do that part.
What is your experience on spasticity management by ozone?
And that it will be difficult to say here because I haven't tried that one. So we can try, of course, because since we are using in many other conditions also we try. But the thing is, we need some document for that. For literature is needed to support.
One of our colleague, Dr. Nilo Kiba, he was working in our CRC Guwahati. He's no
Oh,
more now, but
he is no more.
he was a rampant practitioner of ozone. He used to use
Yes,
ozone in
yes.
all conditions.
Might
Unfortunately, he is
be.
no more, but he is very fond of this practice of ozone in all different conditions.
Mm. Yes, that's why now in many other condition is coming up. People have tried, but the thing is literature is not there. No. So we have to see. So we need more research on this.
How do you convince patient for a spinal intervention, or do you disclose all the risk involved when you inject ozone into the risk?
Yes. In PMR, as you know, as you are also doing, I think we are also doing counseling is very important part of this in our treatment. So before any intervention, before any treatment, even in OPD also, even in cardiac OPD, we do talk patients, we do counsel, and especially in such intervention, we have to do counseling. We have to explain because without proper explanation, patient will not turn up. Because we have to admit for me, I don't know for others, for me, whenever I go for this ozone necrolysis, I admitted patients at least for 1 day on the day for the day of admission or 1 day ahead. So full investigation, just like operation, I do all investigation. And I forgot to mention that before the intervention started, one is to connect with the your pulse oximetry has to be connected because sometimes when patient we keep the patient in prone position, BP comes down, pulse shoots up like that, so heart rate goes up. So we have to monitor that. So
Mhm.
monitoring is very important part. I forgot to mention that part. So patient monitoring is very important part in the management, in the intervention.
There's another question. What are the biomechanical implications of nucleus pulposus hydration induced by ozone injection on adjacent segment disease? And is there MRI or data supporting this?
No, one of my PG student also doing the effect of this one ozone. Uh, he's doing that MRI effect of MRI observation in the MRI after ozone nucleus changes. It's still going on. So what is important is nucleus pulposus, as you know, this is a part of the disc. So where hydration is there, so, where botocalcal chains are there. So water once botocalcal chains are there, water holding capacity is there. So what ozone do is that chain is broken down. So the water holding capacity of the disc that is precognizant by the precognizant is reduced. So this is, as I mentioned earlier also, this is volume size is reduced. With that, so all the effects what we want is achieved. So once this is shrinkage, nucleus pulposus, that is shrinkage. So that is the thing.
Okay, okay. So one more question: if patient is allergic to dye, how we can proceed for ozone nucleus? I think dye is not always required.
That's what. In many of my patients, as I told you, the patient with eosinophilia, patient with this one, any history of allergy, I avoided giving dye. Because that's why one has to go for this procedure when he or she is expert enough or is confident enough. Otherwise, injury to the patient because nerves, patients are there. So we have to think. So anatomy is knowing anatomy is again important part.
Can short-term relief from ozone come at long-term biomechanical cost? No, I think has to be combined. Should be run side by side. You have to go for
Yes.
biomechanical correction along with ozone therapy.
Yes. That post rehab program also I have mentioned little bit
Mm.
about that ergonomic, then care, back care, everything we have to do. So back school incorporating that along with this procedure. It's not that by giving this intervention, everything will be all right. So we have to incorporate. So ours is, as you know already, ours is a teamwork. We have to incorporate everything.
Yes, yes. So there is no more question in the chat box. So that means we have also discussed a lot many questions in the chat box. Thank you, Dr. Nilachandra, for having a good discussion with all participants in this webinar. And I must thank for your acceptance to our invitation for your presentation in this academic webinar. On behalf of Department of PMR, SVNIRTAR, and our IAPMR and APMRO, we are very much thankful to you for your presentation, for a wonderful presentation. I must thank all delegates, all participants for participating this webinar. And from core of my heart, I must thank the office bearers of IAPMR, the PR team of IAPMR, and our office bearers of APMRO, and all my staffs of department PMR SVNIRTAR for helping us organizing this academic webinar monthly. We hope that this webinar will come with more and more academic topics in your future. Thank you very much, sir. Thank you, Dr.
Thank
Nilachandra.
you.
Thank you all
Thank you. Thank you. Thank
participants.
you. Thank you.
Thank you. Good night.
Good night.